Good afternoon. I'm Stephen Wood. I'm here with Ben Potzadlo from Deep Blue MedEd. Today, we're going to talk about COVID-19 and EMS practices. And we're going to talk a little bit about preparedness as well as the efficacy of EMS in the field and some of the challenges that EMS providers face. So, Ben, welcome today. I know you're working today out in the field. I hope it's
yeah, a little bit of both. Yep.
yeah. Hope it hasn't been too busy for you today. I'm glad you could join us and have this conversation. So the first thing I wanted to talk about, and I'm going to mainly do this as kind of a Q&A today, is how prepared are EMS providers for disaster response? I graduated from paramedic school in 1991. And I can't recall if we really had a whole lot on MCI or disaster medicine. It's been an interest of mine, as you know, so I've studied it over the years. But, what's your understanding now of how much education EMS providers receive on disaster response, and how much of that content do they get in EMT school? How much are they getting in paramedic school? What's kind of the framework of educational efforts around disaster medicine for EMS?
Yeah, I think that it's kind of the answer to the question that is that we're that it's a underemphasized, under resourced, and that's the key thing, under resourced. And by resourced, I mean money and funding, but I also mean emphasis and focus. And I think there's some internal issues in EMS around that, the whole culture of kind of downplaying things. But I think what's really important is externally, particularly in the government, the resources brought to bear to resource, support EMS training, EMS time, that not just the training itself, but paying for people to do that training. And then beyond the training is the support for a standing inventory, cachet of the types of supplies we may never use, and the political and public will to do that, to believe that that's important, that we have the resources ready to deal with something like a pandemic or another catastrophic event, and that's something that we believe as a society that we should have in place and is worth the investment. And clearly we see now that we haven't believed in that as a society, as a healthcare system, or as a response entity, that is important, and now we're paying the price for it.
No, I would agree with that. And actually, you raised an important point. A lot of our EMS continuing education is done when you're off duty. And that's different for a lot of fire EMS agencies and for law enforcement. They're typically on duty, getting paid and or getting overtime, where we're usually spending our own time to do these continuing education efforts. So
exactly,
this whole disaster piece aside, that's an important point. And I think, I suspect I know the answer to this question as well, but I would think that a lot of our training is around single response MCIs, multiple victims from a car accident or fire or, ballistics event, anything of that nature. How much training do you think EMS gets, and what do you think their level of preparedness is for what's going on now, which is, prolonged state of emergency pandemic, and how an EMS system is going to respond to that type of, mass casualty event?
Well, Steve, I think you hit the nail on the head there. It's the difference between a spike event and a slope event. So we're more geared towards spike events, as you mentioned, things like active shooter, certainly transportation incidents involving mass casualties, and the like. We're not as geared towards dealing with the vagaries, the subtleties of a slope event, like a pandemic, or even you could have a slope event, certainly wouldn't probably be as long as a pandemic, like a sustained flooding event, which are often extremely catastrophic events that kill many, many people. So, and not just from the flooding, from the downstream effects of it, as it were, of these events. Just like the pandemic will certainly have larger public health effects upon the population other than COVID-19. And these are things that EMS and the acute care health, inside facilities, healthcare system are, really underprepared for, under-resourced for. And I think there's also philosophically, we have don't have a lot of training or preparedness for shifting gears into that type of model. From it's like you said, a single patient or a single incident into looking at things more globally and how we have to treat the population the entire population as an emergency,
Right.
rather than an incident. Yeah.
Right. I mean, you and I were both involved in, preparing EMS providers for the potential for the Ebola pandemic. What do you feel, what do you think the lessons learned from that were, and did we successfully carry over the lessons we learned from preparing for Ebola, to this SARS-CoV-2 / COVID-19 pandemic?
I don't know. It's a good, it's a really good question. I think that, I don't know. What do you, I'd be curious to know what you
I
think.
don't know either. Yeah, I mean, honestly, we lost your video, which is okay, but I think that with Ebola, we did think about supply chain for PPE, donning and doffing, decontamination. I think those lessons kind of got stored away with the equipment. As soon as that was over, everything went away, and we weren't routinely practicing, those kind of events. This is an unusual process. You can't, with Ebola and similarly with, COVID, I don't think you can just go from, being in a scene to jumping in your PPE into the front seat of an ambulance. There needs to be, some decontamination process. And then similarly, we have to understand that, everything's going to go slower. Everything has to, allow for people to don and doff, and our emergencies are going to be run differently. We're going to be taking precautions, but I'm just not sure that mindset, is necessarily there. I think that, we have this idea that, if there's a cardiac arrest, you're going to be running in there, and you're not going to be necessarily having the right gear on. And I don't think that's a safe thing to do. I think we need to make sure that people, get their gear on and then proceed, to protect themselves, to protect their patients, to protect, wherever they're going to be transporting to. We have to take these precautions. So there has to be a change in mindset. We have to really protocolize donning, doffing, and decontamination. And I don't know if those, in some systems maybe they did carry over, but certainly not in all of them. And I think this is something where, like you said, we practice active shooter, rescue task force, things of that nature, but we're not practicing these prolonged events. We're not practicing, hot zone, cold zone when it comes to infectious disease. I think there's a big, area, there's a big deficit there that we could certainly improve on it as an EMS system.
Yeah, I agree with you. I think the Ebola crisis was kind of almost viewed as a, like everyone made fun of it, right? That was a legitimate threat. I think, less of a one than this, but still a legitimate threat. And we prepared for it. And then when it didn't happen, everyone treated like a nothing burger, and it was easy to armchair quarterback and criticize afterwards. Well, look what that kind of, I told you soism has gotten us. It's not helpful to view events where we ramp up and then we're able to ramp down as someone overreacting, because the only way we can be prepared for these types of events is to ramp up early and to have the resources early. And then if we don't need them, it's always okay to de-escalate. It's not overreacting, it's good preparedness. This is done in many other industries. We see it in firefighting, we see it in the military, see it in aviation, and other high reliability entities. But in healthcare, because of the margins, because of the economic pressures, because of the culture, we're left with a situation where we have a just-in-time economy that's really meant for, selling hamburgers or something like that, being applied to critical healthcare, and it's unacceptable. And as healthcare providers and leaders, we can't accept it. In the public, certainly, I'm certain the public won't accept it anymore too.
No, I agree. Yeah, I think you're right. I
We
think
have to be certain, right? We
yeah,
can't go back.
can't go backwards. You need to ramp up early, be prepared, institute, training, and ramping down is always going to be a better thing to do than being caught with your pants down and needing to scramble for sure, for sure.
Yeah,
Um,
ending up having to, have the New England Patriots fly to China to get
Mass.
masks. I mean, it's great, and don't get me wrong. And I give actually our administration and the Patriots all the credit in the world. Our governor did a great job with that. But globally, as national policy, putting states in the position to have to do that is not good national U.S. policy to be prepared.
No, would agree with that. I would agree with that. On that kind of same topic, PPE, so I think this is another area where, PPE is not particularly engineered to be used in the pre-hospital environment. You're out there in the field. How often are you seeing your providers gear up in PPE? What are some of the kind of obstacles that you're seeing them face when they're trying to get this gear on and off, or donning and doffing? And are there any engineering issues that you see that need to be improved upon to help EMS providers, have safer PPE for use in the field?
Yeah. I mean, the first engineering issue is we have to have it, right?
Yeah,
So, and it has to also, it can't be winners and losers. It needs to be organized in a way that is engineered, right? That it's a system of logistics that's not based on who has the most political pull, or who's friends with who, or any of that kind of the vagaries of those things. It needs to be a system. And I certainly agree that the type of PPE we need is, the Tyvek, to use a brand name, the Tyvek suit type, full body suit, rather than just gowns, and all that goes with that, including we should have many PAPRs available, the powered air purifying respirators, and all the logistics that go with keeping those maintained and charged and batteries replaced and all that, and tested, and that we have the canisters for it, the filter cartridges, but also that, we have the N95s, we have the goggles, we have the face shields, but they're of such quality and that we're practicing with them often enough that we're following those processes, and that those are engineered. Because it's not just about putting it on and off yourself or even with your partner. It's about planning to have the resources on scene or in the healthcare facility, that there's that trained observer that takes you through the checklist, right? And it's all about checklists, just like our good friend Sush says, you have to use a checklist. It doesn't have to be my checklist, but you have to use a checklist, and it has to hit the points that matter in a concise but in a thorough way. And it has to be practiced. You have to practice it, and when you make mistakes, you have to fix it.
Yeah, I agree. And I think, and even some basic redesign. So you mentioned the PAPR. The PAPRs have most of the filtering devices are in the back. Well, that's okay if you're, in an emergency department or in an ICU, but if you're trying to drive an ambulance, that's really not feasible. And
No.
there needs to be some redesign around PPE so that, EMS providers can use it appropriately and use it safely.
I agree. Like, things that work well inside a building, like today's a real windy day, and we're out doing response operations today, and we're many of our patients today, most of them are COVID-19 positive or likely to be, and the gowns are blowing around. Not only when you're wearing them, but when you're doffing them,
Right.
and then getting this. So that's something. Is it just you talk about engineering the equipment, having gowns that don't blow all over the place would be good. Or even things like if we're wearing a face shield, if it's windy outside, that's gonna, the wind's gonna catch it. So having ways to secure those things better and make them more secure, and also that if any of this equipment is reusable rather than just immediately disposable, how do we best clean it?
Right.
And when do we to do that on site and turn a unit or in a team around to be ready for the next response? How do we do that thoroughly, but also in a way that isn't taking hours and hours, which has not only a logistical and an operational problem, it actually has a morale problem.
Right.
It's not just usually so physically exhausting, but it's
Yeah.
emotionally exhausting for the crew to do
Oh,
those things, to deal
absolutely.
with all that equipment and clean it all and throw it away and bag it up. And it's a huge, garbage operation ultimately, just for one patient.
No, absolutely. I mean, even on the best of days, I remember, there was one organization I worked with, they wanted us to clean our truck after every call. And occasionally we would just pour some soap on the floor, spray that down, and it would look like we cleaned our truck. And I can't imagine, yeah, I can't imagine having to, decontamination after every single call is just, it's
Yeah.
exhausting. When we think about providers that are working 12-hour shifts, but sometimes 24 or even
Many
48
of them
hours,
working 24. Yes, yes.
it
Many
just
of them working
becomes
24 on
exhausting.
very busy units. Yep.
Yeah, yeah,
It's depleting, it's depleting. And I have to say, I have great admiration and pride in the staff doing this. People have really stepped up. Paramedics and EMTs have really stepped up, and they are doing this stuff. And they are wearing their PPE. They are taking great care of the patients. They're taking great care of each other, and they are doing these decontamination evolutions and getting back in service. And most of the time, heading right out on another one of these jobs to only do it
yeah,
again.
yeah.
So, and trying to get, in between it all, trying to get clean enough that they can get somewhere and socially distance and eat or get something
Right,
to drink, use
right.
the restroom, whatever. So it's
Any of
the
those
whole
things.
thing. Yeah. And it's just, I think the hospital, it's admirable too. But I think the difference is that logistically, that's in EMS, it's that much more challenging maybe because our facilities are, they're not necessarily all in the same place. And, there's the vehicles and we're down with them. You can't kind of just, there's no break room really, unless it's a quiet lull.
Right, right. And that kind of speaks to something else, which is, the hospital's responsibility to EMS as well. My
Mm.
hospital actually does a very nice thing. They have a nice break room, and we, have meals that are provided every single day. And they're not just your turkey sandwich. They do hamburgers and hot dogs and, fully cooked hot meals. And they're out there every day. And they've actually ramped that up during this crisis, knowing
Really?
that, yeah, knowing that people, yeah, stop by. They actually have
Yeah,
some really
I'll wear
great,
maybe on my day off, I'll wear my uniform down there.
and just go on down and have dinner because they actually have some great meals. But it's great to see that because it means that one, we recognize like these guys oftentimes don't get a single break, and they're in
Really
full
nice.
gear.
Thank
They have to doff that gear and then go to the next one, and it's great to have some place for them to kind of sit, eat, or even just grab something to go. But there's also a responsibility, I think, for hospitals to, and this should be something part of the engineering of hospitals, is that we have an area for EMS to safely doff their gear, clean their gear. It shouldn't be that they're taking that stuff off out in the driveway of the hospital. We should have designated areas, and even to the extent where there could even be a shower, certainly hand washing stations, but even a shower, so that if they got contaminated, they can safely wash that off and get back in business. We've every hospital has a little bit of a area for EMS. It can be anywhere from a small desk in a corner to, I've seen some great break rooms with computers and fridges and all that. But part of this is that they need an area to safely doff, to decontaminate, to clean equipment, and that's the responsibility, I think, of hospitals to really take part in the EMS system, to ensure that these things are done right. And we shouldn't be cleaning stuff off in the driveway and having contaminated water run down into the local sewer system or down the street.
That's a
Uh,
really good point.
yeah,
Like, there's so many different details to this. I think that what we're finding is that we thought we knew what some of them were, and we're finding new ones every day, things we didn't even think of that just emerge. And I think we're trying to use that debriefing process that where we identify things that went well on our runs, things that didn't go well on our runs, and then we're able to say, geez, we've never encountered something like this before because it's so unique. This type of, like you said, this slope to sort of sustained drain on the healthcare system and on emergency operations, that we're identifying new things every day that we have to be like, geez, well, how do we work around that? What's our new kind of best practice to deal with, large amounts of PPE, or needing to clean large amounts of N95s, or trying to, at least. So
Yeah. We only have a few minutes left, so we'll end on a topic we could probably spend a whole hour on, which is kind of redesigning the EMS response during this, and thinking about certain protocols. And the protocols that come to mind are, one is not transporting non-emergent patients who don't need to be brought in by ambulance. I know in systems that I'm working in, there are patients that will call 911 because they want to come in and get a test. They might be asymptomatic, but they'd like to get the nasal swab. In our current system, you're taking that patient in. There is a protocol I know that's now in place in Massachusetts that has helped to potentially alleviate some of that, but it's complex. So I'd wanted you to talk about that. Like, how do we effectively say, you do not meet emergency criteria for ambulance transport? How do we effectively do that? And then on the other extreme is, and we've talked about this offline, when you come in on a patient who you suspect is COVID-19 positive, who's in cardiac arrest, the do not, even if DNR orders are not in place, just making a determination that the safety of the patient, crew, and community are just too high to initiate, resuscitative efforts. What are your thoughts on both of those kind of extremes?
Yeah, I think those are really good points there. I think the Protocol 1.3 in Massachusetts, I think it's really well intended, and it at least is a first bite at the apple. Whether it's just for COVID-19 or beyond, for other future similar sustained disaster situations, I would argue that EMS needs to be trusted. We need to lose some of this paternalistic approaches and to it that doesn't trust paramedics and EMTs to make good decisions that are in the best interest of patients. I think providing good criteria is helpful, but once it becomes Byzantine, like I think that protocol is fairly Byzantine, the output of it is going to ultimately be very few people are helped by it. Because I think there's a big help to public health and the individual patients with not transporting people who are have mild disease or merely anxious, as well as also not having a lot of heavy contact with them. And I understand in coronavirus we're worried about silent hypoxia and things like that. And perhaps there's an argument that we need to go out and check everyone's O2 saturation or whatever. And I'm open to that. If someone calls an ambulance, maybe we need to check their O2 sat.
Yeah, that's perfect.
I don't know.
Yeah.
I don't know, but not every has it. So,
yeah, I mean, honestly, I consider that the best test for COVID-19 is the pulse. Yeah. The swab, is what it is. But putting a pulse ox on and seeing what your oxygen saturation is, to me, has been my most effective tool for identifying patients in the emergency department who I suspect have COVID-19. Get the pulse ox on. If it's 82 and you're talking to me, then you probably have COVID-19, swab or no swab. All the other things we get, the x-rays, et cetera, are going to be supportive to that. But that's my first 5 seconds. You get a pulse ox, and if it's normal, you might have COVID-19, but it's probably mild. If it's 80s, then you probably have it. And the other tests are of limited benefit, except when making other decisions for us in the hospital setting. But that's kind of the quickest and easiest test to do. So yeah, I agree with you in that regard. How about go ahead.
Keeping it more less a little bit more simplified as far as the pathway on it. It's kind of a little Byzantine. I think it's important that we hit all the big clinical markers on it, but I just think the other thing is that ultimately some of these decisions, if we're going to be practicing true disaster medicine to the scope and scale that we're confronted here, that the ultimate decisions need to be made by the EMTs and paramedics and not be left to the public and individual callers to decide, well, I hear what you're saying, EMT or paramedic, but I still want you to take me to the hospital, and you have to, and then we have to. That's not real disaster medicine. We need to be able to tell people no. Now, I'm not saying tell people no and we're not going to do anything for you. Tell people no, we're not going to take you, but we are going to make sure that you're in contact if you don't have a PCP with a healthcare practitioner who's can provide you support and advice, and that you're going to be tracked so that you,
Yeah.
someone's going to be in contact with you, so that if you do get worse, we can get you transported, get you cared for, and get you into the system. And we also can, care for you otherwise. But to me, it's more about treat and refer. Oh, did I lose you?
Yeah, you got me. You're back. Yeah.
I think I'm running low on battery power.
Yeah.
I think it's more about treat and refer, not treat and release. As far as the cardiac arrest, I would say that, I think there's situations that it's situational. And again, it comes down to trusting your paramedics and having, good rapport with your medical direction. And if we have highly skilled paramedics that frequently see cardiac arrest patients and are highly skilled, they'll know which patients should be, aggressively resuscitated and which patients are, for example, an unwitnessed patient who has a no shock advised or does not have a shockable rhythm and the arrest was not witnessed in this type of situation. I think it's reasonable to not work those patients, and they weren't last seen alive within the last, short while. Then that's reasonable. Whereas if it's a witnessed arrest and there's some sense of viability, that's much different. Or if it's not believed to be, from a very, very aggressive and often fatal disease. As far as a witnessed or near witnessed COVID-19 related cardiac arrest, I think that's, the bioethicists are struggling with that. I know in New York City just now, they put a protocol in place to not resuscitate those patients, and it was within a day or a short while was rescinded. So there's a lot of tension around that kind of, treating the individual and the individual's rights versus the population's rights in such a disaster. So it's an interesting and, terrifying moral ethical dilemma. So
yeah, no, agreed. All right, great. Well, Ben, it's been a pleasure. I know you're busy today. I want to let you get back to work. Again, this is Ben and Steve coming from Deep Blue MedEd, talking COVID-19 still. It's on everyone's mind. We'll be back with you next week for another episode. Thanks again, Ben.
Thanks, Steve. Take care.
You too.